First of all, really, this is our institute. As a first chance, I like to pose a question to you, those who are preparing for the Part 2 exam. Please try your best. I don't like to hear any answer from you now. Just look at the picture, look at the question, and have your answer with you, really. We will ask you the answer later part of the discussion. Finally, after the talks will be over, then we will interact with the picture. You just keep the answer with you now. But if you don't understand the question, you can ask me. I think the question is very simple, very easy. A female patient presented, the 42-year female presented with fever, chills, and mild confusion. Means having some brain dysfunction. Confusion means the exact challenge is to the fundoscopic view. So our discussion is to have this a challenge and how can we solve the problem. So for that, this is the first scenario to you. And just to start the fundoscopy, really, we must know some basic things. And we discussed in the last classes. We provided a small PDF to you also in the group. Even then, we refreshed it. So this is the picture showing all the normal characteristics in a fundoscopy. So it is written in the left side. If you want, you can make a snapshot if you need from there. Very interesting thing is the color of the disc is more important to exclude optic atrophy, you know, from previous time. In the center, this is macula. These are the vessels and the normal color of a fundus. It is given. Just for my interest, may I know, can anybody say from which side of the body the fundal photograph taken? In the left or right? Please quickly, anyone can write in the chat box. For my interest to know. It's anatomy question. Is it left or right, please? Anyone? Can you write? Dr. Zaman Faryal, Dr. Beg or Sayyida, anyone? So don't write to right.
Right.
You are thinking this is right. Any difference opinion? Any difference of opinion? What do you think? Everybody the same opinion or confused maybe? Confused maybe. Okay, everybody can continue your thinking. Which side the optic disc remain and which side the macula is there? So this is the superior temporal artery actually, the inferior temporal, in between macula and the less vascularity around the macula. And macula is for the direct vision, central vision. So this is optic nerve head, and we focus the fundoscopy obliquely. We focus the fundoscopy obliquely from the temporal part. So this is challenge for Faryal. Try to identify left or right side later. We are going to the topic again. So again, this one, and we have shown in the last class, clinical evaluation. We are not practicing this thing as a thesis candidate here. These are the basic informations when we evaluate an eye problem of a patient. So these are the checklists can be with you even in the part 2 exam also. When the question is given to you, you can identify the problem scrutinization with these structured information. In the question, some information will be very obvious, one-sided or both-sided. Well, so now the question to you, as it is interactive session, we feel it better. Is it normal or abnormal? This is the question. Please, anyone. I think you can make unmuted yourself and you can tell. Dr. Faryal, Mahbub, or other colleagues. Is it normal or abnormal? In your observation? Dr. Faryal?
Sir, looks normal.
Looks normal. And other persons are silent. They are waiting for us. Yes, thank you. This is normal, really. So this is the optic disc, and the vessels are coming from the center. Try to remember my words. The vessels are like spokes in a cycle tire. The vessels are coming from a center. So vessels are actually radiating and accumulating towards optic disc. This is one way of identifying optic disc in the practical fundoscopy. So why this is black, Dr. Farial? You are telling that this is normal, but previous one was not that much black.
Yeah.
Possibly is a negroid patient.
Yeah.
Negroid patient. Got that. So quickly, who can answer this? What is this diagnosis? Look at the picture. Look at the disc. Look at the vessels. The remaining retina quite normal. Quickly, please. Can anybody say the answer? Then we can jump. No one.
Sir, optic neuritis.
Optic neuritis is the pathology, but appearance is
Appearance.
optic atrophy. You mean
Optic atrophy.
optic atrophy? You mean optic atrophy? Is it primary or secondary?
Primary.
Primary. Mabuk,
I'm not sure, sir.
you're not sure. Farial, why you are telling primary? Quickly, please. Somebody,
Because the margin, the
margin is
quite sharp, maybe.
in your observation. Margin is very sharp. Yes, our observation also sharp. Distinct margins. Sharp means
Distinct
margin, and
Yes.
remaining fundus is quite okay, and the color is pallid. Pallid means pale. Pale. So actually, it's a puzzling picture that it seems to be normal color, but actually, it's practically this is not primary optic atrophy. It is not normal color, and it is clearly actually written in the book as well. So this is left side or right side, whatever it is. Again, we can identify by looking at the arcade. Actually, this is not actually the. It is right. This is right. I have given a text only for understanding the patient, but this is actually right. This is arcade, temporal arcade of the vessels. The bigger one, superior, inferior, and macula possibly in this area. So this is right. Now the informations, very important informations. This is the primary, secondary, and the consecutive optic atrophy. In the consecutive optic atrophy, retina will be in disease. Always you can hear me that I uttered the word retina is okay, okay. So actually retina okay means it is primary optic atrophy. And in the secondary optic atrophy also retina may be okay. But consecutive optic atrophy, there may be retinal vessels or retina itself in disease. This is the consecutive atrophy. And I think this picture can delineate this well, can explain well. This is the primary, secondary, and the consecutive. You see the retina is in problem, vessels attenuated. There are many exudates and other things. So this is the retinal disease. Subsequently involve the optic atrophy. Again, the border is relatively sharp here, distinct, but white. Optic disc is white. So this is again optic atrophy. And this is the blurred margin with white optic disc. The remaining retina almost quite okay. So this is secondary optic atrophy and this is primary atrophy. There's some informations are given here. You can go through the book also. So now what is this actually? This is also disc. The margins are not sharp. Margins are white, but there are some associated finding in the surrounding. This is cotton wool spot. Cotton wool spot. So it is not like previously shown primary, secondary, or consecutive optic atrophy. And the vessels are blurred here. So vessels are blurred here means in the center also. What does it mean? There's a basic thing. This is edema. There may be edema, maybe inflammation. So this diagnosis would be, we discussed in the last time, actually, arteritic ischemic optic neuropathy. Arteritic, so there is inflammation of the vessels. Inflammation of the vessels. So one good example in the elderly patient, you know, the giant cell arteritis. So disc is pallid, edematous, hemorrhage also a little, not much clearly visible. Small points of hemorrhages are there, and adjacent cotton wool spot. So this is the white spot is the cotton wool spot. Cotton wool spot means infarction. So this is edematous disc and arteritic ischemic optic neuropathy. In these two pictures, this one actually shown before, relatively similar picture. This is arteritic, but in this picture, the white areas are not visible like there. So this is reddish rather. So this is non-arteritic anterior ischemic optic neuropathy. Non-arteritic. That means maybe vascular occlusion is there, hyperlipidemia and other consequences, thromboembolic maybe. So these are both are again optic neuropathy. We are not telling these are optic atrophy. The better word is optic neuropathy, and this is ischemic. Both are ischemic. One is non-arteritic. This one is arteritic. So we can expect this type of picture from giant cell arteritis, right? Polymyalgia, rheumatic background. Very often you have to face such question in the exam. And this one, it would be better.
Papilloedema. Papilloedema.
Papilloedema. Papilloedema. I think everybody is okay with this opinion. This is papilloedema and visual field constricted. These are associated eye examination findings. With papilloedema, the bilateral is bilateral vision loss. We term it papilloedema. But in unilateral feature, we term it actually papillitis. Papillitis, this edema with inflammatory nature appearance. So this is papilloedema and the blurred optic disc and reddish hue, not white. So if subsequently it become white, then it would be secondary optic atrophy. Secondary optic atrophy. And I have shown in the yesterday, this is a live actually one video in the benign intracranial hypertension or idiopathic intracranial hypertension. There is a spontaneous vascular, there was pulsation is there normally, sometimes it is visible, but in the raised intracranial pressure, idiopathic intracranial pressure, the vascular pulsation is lost. I think, would you like to view it again or not? Dr. Farial, did you see before the last day?
No, sir. Spontaneous, no, sir.
Do you like to see? Sorry. Just few seconds. A few seconds. Look at the center. There's a yes. Look at this.
Yes.
Can you see that pulsation is there?
Yes, sir.
It is called spontaneous retinal venous pulsation. Usually, it is rhythmic. You know, according to the rhythm of the heart, caliber is being more or less. This is they cross the optic disc. The vessels are now crossing the optic disc. It is normal finding if we are very meticulous in the fundoscopy. Anyway, thank you. So in summary, to differentiate the papilloedema, these are the optic atrophy. So if this is the optic atrophy, who can say which type of optic atrophy, primary, secondary, or consecutive? Quickly, please. May I request Dr. Saida and Dr. Sahir Athar Beg? You can be with your voice, please. Don't feel shy. Which type of this, primary, secondary, or consecutive? It is not written in the caption, for that I am asking. Easy. Can you see the
Consecutive.
Consecutive? Is there any retinal disease or retinal vascular disease? No.
No, sir.
So
Then it is primary. Yeah.
So it is not consecutive. Is the margin blurred? Dr.
Yes,
Saida,
somewhat.
Dr. Saida, what do you find? What do you find, Dr. Saida? Is the margin blurred? Mahbub, this is blurred margin.
Yes, sir. Margin is blurred.
Margin is blurred. So it is actually successive changes of this papilloedema. This papilloedema. So this is secondary optic atrophy. Secondary optic atrophy. Good. So now what is this diagnosis? Can anybody say rapidly? You may do mistake, don't worry, we will correct.
Primary optic atrophy, sir.
Primary optic atrophy, because you are thinking that there is a white optic disc. What about the border? You
Sharp border.
What about the vessels? What about the vessels? Is coming from the center? Is a normal optic? Is the vessel coming from the center, like normal optic disc? That means from the central point, vessel coming?
Yes.
Yes, Dr. Mahbub? I think I am not with the same opinion of Dr. Farial.
No, sir.
Vessels are not coming from the center.
Come from the
Yes.
center.
Yes. Not coming.
So vessels are pushed apart. Do you agree?
Yes.
Vessels are pushed apart. That means there is more pressure inside the optic, inside the eyeball. This is the glaucoma.
Okay. Yes.
The white area is optic cup. This is the optic cup. Usually it is less than 50% of the total diameter of the optic disc normally. And significant widening of the cup is called actually glaucoma, raised intraocular. Ocular means the inside the eyeball pressure is high. So retinal vessels actually pushed. This is the confusion with optic atrophy, as these are also white area, but these are for the cupping. And the pressure also causing the optic atrophy, no doubt. And it is called glaucomatous optic atrophy. Glaucomatous optic atrophy. So just to compare, Dr. Farial, from the picture above and the down, the vessels are coming from the center. This is normal.
Yes.
And very small white area, this is optic cup. So it's becoming bigger and bigger. So this is glaucoma. Chronic open angle glaucoma. Chronic open angle glaucoma. So what is this? Look the color of the retina. Look at the vessels. Look at the disc. Seems to be abnormal. And there is a pointed arrow mark is there. There is some finding also. Please, anybody can say the answer?
The central retinal artery occlusion.
Central retinal artery occlusion. What are the points in favor?
Sir, pale retina with red spot with pale retina.
Red spot is the macular area.
Yeah.
So what is the spot name? Is there any name of the spot?
Yes, sir.
Anybody can recall? Anybody can help Dr. Farial? He is struggling with the name. What is the name of the spot? If it is central retinal
Macular.
Area name is the macula, but is the red spot. Macula actually black spot, rather to say. Macular area less vascular in the normal fundus, but the fundus relatively white, pale. So the vessels are becoming red really. This is called cherry red spot.
Cherry red spot, yeah. Yes, sir.
Right, Dr. Farial? You know it.
Yes.
I forgot. Okay.
Sir, forgot, yeah.
Cherry. Is the vessel normal? Vessels?
Yeah.
Vessels number are less, and these are attenuated. If Dr. Saida, can you say is the disc is normal looking? If the disc is normal looking, be interactive, please. Now, welcome, Dr. Rafid. You are just attended. Now, Dr. Rafid, can you see? Is the disc is normal? Hi, Dr. Rafid. Can you hear? Anyone? Dr. Mahbub, is disc is normal looking? No. Disc also not normal looking. We are very happy having cherry red and the pale retina. We are diagnosing that central retinal artery occlusion, but it's better to identify all the features. So this is really central retinal artery occlusion. That means crow. So the basic information is given in the slide. Very, very helpful information for you. This is central retinal artery occlusion, and the disc is abnormal, a little pale, right? A little pale. Yes. And a normal fundus compared in the right side. And here, actually, the vessels description is not clear. This is called boxcar segmentation of the retinal veins. Boxcar segmentation. Boxcar. That means interrupted retinal veins. In the severe cases, artery also is having this appearance, the advanced cases. So there are boxcar appearance in the veins. There is a cherry red spot, and the disc pale. The all over the retina is pale, pallid. So diagnosis is central retinal artery occlusion. So why the cherry red happened? Please look at the picture. It's very nice picture. Is the central retina is occluded? Which one? Which one central retina? This ophthalmic artery. From here, a central retinal artery arises, and this is the central retinal artery. So it is giving the blood supply, most of the retina. It is blocked somewhere by the clot or something. But there is small other vessel you look at. This is short posterior ciliary artery. Short posterior ciliary artery. It also gives blood supply to the macula, central vision, right, in the macular area. So if the central retinal artery is occluded, macula is getting the nutrition from this additional blood. So in the pale retina, this vessel becoming redder than the non-occluded retina. So this is the cherry red spot. This is the explanation of cherry red spot. But if it is in the block in the ophthalmic artery, you see this is the ophthalmic artery. So this cherry red spot will not be there because blood is not going to this artery as well. So in the ophthalmic artery occlusion, the retina will be pale, but cherry red spot will not be there. I think, is it clear, Dr. Faria?
Yes, sir.
Good. So what is the diagnosis? Please try to understand. I hope that you will feel free altogether, please, to be interactive. Is there any pale retina, Dr. Mahbub? Is there any pale retina? Part
Yes,
of
sir.
the pale. So pale means less
Yes, sir.
vascular, less vascular.
Yes, sir.
Is any vascular territory, is it following? Yes.
Mm,
This is the temporal,
yes, sir.
inferior temporal territory. Yeah? This is called superior temporal territory. So this is less vascular. There may be vascular occlusion. So is there any cherry red spot? Is there
Yes,
any
sir.
cherry red spot? So what could be the
Yes, sir.
diagnosis now? What could be the diagnosis now?
Segmental
Segmental. This is called branch retinal artery occlusion, not
branch.
segmental.
Yes.
So it was previously it was crow, and this is the brow. Branch retinal artery occlusion. But you remember the part 1 exam, identifying the picture, but underlying disease you have to identify maybe what may be the cause, Dr. Farian, of such a blockage of the vascularity in the eye. It may be in the brain as well. Patient might have ischemic stroke.
Yeah. Yes.
So high coagulability state, maybe vasculitis or non-vasculitic, right? You know the Behçet's, the part 2, I told you before also. Behçet's disease is actually presented in the part 2 with this vascular phenomena, not but orocutaneogenital syndrome. Oral
Okay.
cutaneous
Yes, sir.
genital syndrome. It is a very part 1 information, just understanding. But in the part 2 information to diagnose Behçet's disease, more often it is found in the exam by these vascular phenomena, iritis or this vascular occlusion, maybe underlying disease, we don't know. We could identify many reasons of this vascular occlusion. This is branch retinal artery occlusion. What is this? Is there any vascular occlusion? Is there any ischemia in the retina?
Yes, sir.
Yes, this is the white area. There is some area retina under less circulation. So there's some vessels actually not occluded from very proximal part, maybe in the distal part, and there is a white spot. Seems to be this is the thrombus is impacted here, and the distal part is occluded and showing the what is the appearance? Wedge shape appearance, right? Any artery is blocked, the distal area will lack of blood supply in a wedge shaped manner. Everywhere it is true. It is true in the brain, it is true in the lungs. So infarction in the lung, infarction in the brain, everywhere the infarcted area will be a wedge shape. This is depend it for the branching pattern of the blood vessel. So this is white spot. This is thrombus. It is also vascular occlusion. Right superior temporal branch of the retinal artery thrombus with infarction. So this is white area is infarction. So we must be oriented with many different appearance of the retina. So this is very, very red retina, extensive bleeding. And some cotton wool spots are there, but these are hidden actually because this is a bloody area, very extensive. What could be the diagnosis? Please feel free to answer. And the disc also not visible almost. Some vessels are visible, few. What could it
It is hemorrhage.
This is sunset appearance. The storm is sunset.
Storm sunset.
What is the diagnosis?
Is it a retinal vein occlusion?
Central retinal vein occlusion.
Thank you, doctor.
Meningococcal.
Central. No, this is not infection.
Oh,
Central retinal vein occlusion. Right central artery occlusion. So the difference, basic one, arterial occlusion causes retina pale. Venous occlusion causes retina red. Very easy to understand. Because the venous block, the blood is not going towards the heart. So blood becomes stagnant in the retina. So retina is red. In the arterial occlusion, blood is not coming towards the retina. So retina is white. One thing. Very extensive. This appearance actually may confuse you with hypertensive retinopathy. Hypertensive retinopathy. So today my plan to complete, to go for a complete discussion. If you remain with me really, I hope that you will be passionate with me to finish today's chapter. And in the hypertensive also there is hemorrhage, but not this much. We say in hypertension, this is what is that? Little Farial, can you remember the word in the hypertensive retina? The bleeding nature is flame-shaped hemorrhage. Flame-shaped hemorrhage. And disc may be what's that? Papilledema may be there. There may be different grades of hypertension, wearing, silver wearing, copper wearing. I will show you today. I hope so. So this is extensive bleeding throughout the retina, and this appearance is very likely and very common in the exam and very easy to understand. Central retinal vein occlusion. So what is this? Again, this sectorial. Just giving you a clue.
Branch retinal vein occlusion.
Branch retinal vein occlusion. Very good. So this is branch retinal vein occlusion. BRVO in the upper territory. There are some infarcted area. White retina means infarction, and the appearance we call it cotton wool spots. Cotton wool spots means infarction. So fundus is normal. Dr. Zaman, is fundus normal? Is the optic curve visible?
Optic curve fundus is normal, I think.
Optic curve is not more than 50%. Further, we cannot tell
Yes,
that
sir.
there is glaucoma. But there is definitely optic curve is clearly visible. You see the vessels are actually apart a little, not exactly from a central point. But this is also normal. This is also normal. So up to this, really, I just had chance to review previous classes. Many of you couldn't attend maybe on that day. Just a short review for that. I think it is helpful for everyone. So now in this break, really asking you if you have any, again, further question, what I told up to now. Just take few seconds, think yourself. I'm ready to discuss. If anybody wants to ask or share any opinion. I'm not ophthalmologist. It's for your kind information. Just as an internist, as a clinician, and a member of Royal College, just to discuss something important for your exam. And these are very important appearance in the clinician's view. As a clinician, as an internist, we have to identify this type of picture in the fundoscopy. And I told on that day that the fundoscopy really a neglected subject in our clinical practice. And it should be learned in the undergraduate time also. Very unfortunate. Okay, I think I don't have any further question. Anyway, if it is better that you can understand, I'm very happy. So we can jump to the next one. Very simply, who can say the diagnosis? If anybody gone through this class, straightforward answer.
Cataract.
This is cataract. Yes, the haziness in the red reflex, right? The red in the red reflex. This is normal. This is cataract. Very good answer. Very good answer. So these are the basic informations in cataract. I think you can make a snapshot, please. Is enough for you. And their lower part is very exceptional information. It is not important for part 2 preparation. It is important for advanced stage. But these informations are very basic. If you don't understand this information, you may miss the diagnosis. So I have actually kept the basic information appearance. Okay, what is this? What is the diagnosis? Did we discuss it before? Possibly. I'm sorry, I cannot remember. There are multiple yellowish spots surrounding the macular area. Vessels are almost normal. This seems to be normal, though optic cupping is there, but not significant. So what is the possibility? I am giving a clue that patient is elderly. Patient is
So
elderly.
Drusen.
Drusen.
Yes, sir.
Drusen. So can
Yes.
you make a little better diagnosis? It is Drusen, no doubt.
Macular edema. Sir, macular edema.
No.
Macular
No, there is
degeneration.
Yes, age-related
Macular degeneration.
age-related macular degeneration. Drusen may be a normal phenomena, but when we level age-related macular degeneration, there are some characteristic features.
Yes.
I think you can make a snapshot. Right? I don't know, my picture is good looking to you or not. So what are the types of age-related macular degeneration? Can you come in interaction with me, please?
Wet and dry.
Wet and dry. So this is wet or dry? Mahabub?
Dry, dry.
This is
This
dry.
is dry.
This is dry. When we will tell this is wet?
When edematous. Yeah.
Edematous. How can you identify edema in the macular area?
So there will be
Redness.
redness. Redness with
There will be neovascularization.
vascularization.
Usually, macula is having less vascular, that means vascular twigs, which is visible in the fundoscopy in the central part. But somehow abnormal vessels can proliferate here. So this is choroidal neovascularization, not in the retinal vessel. Remember, the vessels in the choroid. So it's very difficult to comment, and practically it may be important picture in the part 2 exam, but not for patients, because clinically patient will have very rapid loss of vision, very rapid vision in the weight transformation of a dry retina, a dry AMD. Can you understand my word, Dr. Parian? In general,
Yes.
age-related macular degeneration is dry. But
Yes.
anytime there are some factors upon there causes a rapid diminution of the vision, and retina may become changed in that manner. So there is a drusen, no doubt, but the nature of the drusen is it has some colloidal osmotic power. So what does it mean? If there is any colloidal osmotic power, it will pull the water,
Okay.
and then macula become edematous. This is one. Second, subsequently, there may be development of choroidal neovascularization. So few vessels are there. Why this is choroid? I will tell you in the subsequent other part of this. So in the up to now, I just add some words. It would be better to tell earlier. You know the layers of the eyeball is retina, then choroid, then sclera. So there are some diseases involve the retina only. There are some diseases involve retina and choroid both together. So when we will tell that the choroid is involved, if we see that there is a pigmentation, you know, the nature of the choroid is pigment. The basal area in the retina is the pigment layer. So if the pigment is visible, then we tell that there is choroid. So in this first picture above, are we seeing any choroid layer? What do you think? Any choroid is visible here? No. We are seeing only retina. These are the retinal vessels. And center, there is drusen. So, if the degeneration is progressed, then the choroid may be exposed. So, this is that picture. Okay. What is this? So, look at the disc, look at the vessels, and look at the whole area of the fundus. Then answer.
Retinal hemorrhage.
Okay.
And capillary edema, silver wiring.
Silver wiring, can you see the silver wiring? There will be thin narrowing of the vessels. It is the silver wiring.
No, sir.
May not be, maybe. There may be, veins are usually dilated. So what could be on an average observation telling you the diagnosis? What could it be? The optic disc is blurred, red, edematous.
So this is
There are some hemorrhages. What is the shape of the hemorrhage? What is the shape of the hemorrhage?
flame shaped.
If it is characteristically flame shaped, what could be the diagnosis?
Hypertensive retinopathy.
Fantastic. Hypertensive retinopathy. What could be the grade?
Pre-proliferative.
Pariyal, we don't use the word pre-proliferative in the hypertension. We use the word in the diabetes.
Yes.
In the hypertensive grade 1, 2, 3, 4. What could be the grade?
Yes.
It's grade 4. As papillary edema is there.
This is grade 4. Right, Dr. Mahabub. Thank you. This is a grade 4. This is a grade 4. So grade 4 means this is the progressive nature of the damage in the retina by hypertension. So this is grade 4 hypertensive retinopathy. This was, I was telling you before, the central retinal vein occlusion may be a differential appearance of this picture. But in the CRVO, there will be extensive redness. Extensive redness. So these are the 4 grades. Don't forget. Grade 1, 2, 3, 4. This is progressive nature. But interesting information I put in the previous slide. I am going back. In the lower part, papillary edema usually indicates severe hypertension, but it can occur anytime and even in the absence of other features. Other feature means different grades of hypertension. So maybe retina looking normal, it could be again papillary edematous hypertensive retina, but this appearance is less common, not much common. So please look at the different grades of hypertensive retina. The white line, this is the silver wearing, Mahbub. How clearly visible. The silver wearing, there may be copper wearing also. I will show you how to differentiate the copper wearing. Rather, in this second picture, grade 2, copper wearing is visible. This line, can you see this line?
Sir.
There is a strip of white, strip of rather to say blood column is visible, but in the center there is a whiteness or yellowness. But here the whole line is white. So this is silver wearing, this is copper wearing. So which one is earlier picture of copper wearing or silver wearing? What do you think?
Silver wearing.
Silver wearing. I think no. I think no, because this is a complete occlusion. This is partial occlusion. Partial occlusion. So this is previous, but we may not find both features together in the same picture. Same picture. Okay. So in this picture, you see the wearing is not much visible, but there is exudate. Vessels are attenuated, thinner. There is flame-shaped hemorrhages. Flame-shaped hemorrhages. Optic disc seems to be blurred, but clearly blurred in this picture. So somebody can tell that this is grade 4. If somebody may not tell, it is also accepted as the author also telling that this is not grade 4, but in the right side, this is grade 4. So cotton wool spot is very characteristic in the grade 2. Okay, arteriovenous nipping. You see the crossing vessels, just crossing. Vessels always cross there, but nipping, nicking, compressing the neck feature. This is called nipping. This is characteristics of the grade 2 hypertension. Okay, clear? So just to show you, this is white. What is the name of that? Silver. So blood column is not visible. This is silver wearing. But here, the blood column is visible in between, right? There is a central line. Beside there is a blood column. So it's not completely occluded. So this is the copper wearing. So blood column is still visible. Copper wearing, silver wearing. So now, if this is the hypertensive retina, this appearance may be confused with other diagnoses as there is bleeding. So retinal artery occlusion, you have seen that retinal artery occlusion, okay, retinal venous occlusion, which is actually more be confused with the artery or the vein. What do you think?
It's a vein occlusion.
Rather venous veins maybe. Why retinal artery occlusion is mentioned there? Because the retinal artery occlusion also can produce damage in the retina. So at that time, patient might have together hypertension. So there may be in between hypertensive findings are there. So they may give a mixed picture actually. But typically central retinal vein occlusion will give a very good differential with extensive bleeding. Ocular manifestations of some infection also, especially HIV and other infectious disease also can produce some bleeding retina. I hope that I can show you today. Then optic neuropathy, especially anterior ischemic optic neuropathy. You have seen that before in the optic disc, there is surrounding some bleeding, the redness. So appearance may be confusing, but typically there are 4 grades of hypertensive retinopathy. In the part 2 exam, I think that's enough. Minimum, we have to know it. The different grades of hypertensive retinopathy. So now look at the picture. What could be the diagnosis?
The hypertensive retinopathy.
Hypertensive retinopathy. Why you are telling? Is there any silver wearing, copper wearing?
Sir, there is a cotton wool spot. So and also flame hemorrhage.
Flame hemorrhage? No, these are blood hemorrhage.
Dot hemorrhage.
Dot and blot.
Dot and blot. Yes.
Any other observations in the retina? There are some, you see, there are some vessels.
Neovascularization.
If it is neovascularization, could it be hypertensive?
No, it's diabetic retinopathy.
So neovascularization typically suggestive of diabetic retina. So what is the category of the diabetic retina? Background, pre-proliferative, proliferative, or in another way, proliferative or non-proliferative? NPDR.
Proliferative.
This is proliferative.
Proliferative.
So the very, very characteristic feature is what?
Neovascularization.
Neovascularization. So these may happen as the diabetes is a vasculopathy. So there is ischemic retina may be there. Though it's very suggestive in the hypertensive retina, but diabetic retina may have. So this is actually diabetic retina. It is beyond the disc. Disc is there, very, very peripheral part of the picture. So the white areas, it is a cotton wool spot, and it is very regular, clear border. What could be the name of this spot? If it is cotton wool, what could be the name of this? The lower part. It might be exudative. Exudative means hard exudate. Hard exudate maybe. Hard exudate, the difference between here you can observe by your eyes is it's a little clearer outline than this one is a diffuse outline. You cannot tell what is the boundary. So these are cotton wool spot. This is exudate. Typically, these are exudates, but these are not exudates. Initially, the last days, a few years before, it is told cotton. This is called hard exudate, soft exudate. But term is changed because these are not actually exudate. So don't tell the word soft exudate, rather tell it cotton wool spots. So there are some IRMA, fluffy cotton spots. Cotton spot occur in association with IRMA. Maybe there are IRMA. I will show you what is IRMA in the subsequent slide. Okay. Extreme right of the photo 9, extreme left of these areas, cotton spots. They are mentioned in the location. So what is the appearance telling to you? These the vascular damages are there. So there is optic atrophy, right or wrong? Optic atrophy.
Optic atrophy.
The white retina. But our attention is towards the retina. What is the diagnosis of the retinal changes?
Sir, pigmentosa, retinitis pigmentosa.
Photocoagulated, laser photocoagulated retina.
Why not retinitis pigmentosa, Dr. Mahabub?
Pigmentosa, we can find in pigmentosa the speculed retina.
Spicule appearance of the
Yes, sir.
periphery of the retina.
Yes, sir.
Okay. But there are some spot black, right? This application of the laser, these are the spot red. Just I'm telling by my words, real. I'm not telling from the book. Spot area, right? So it is laser phototherapy commonly done in the diabetic retina. So one question in the last days, actually photocoagulation given to the new vessels or elsewhere? Who can say?
New vessels.
New vessels. Any difference opinion? No, not in the new vessels. It is actually damaging the ischemic retina because ischemic retina is the stimulus for the new vessel formation. So where is the ischemic area? That is white area, cottonwool spot. These area actually given the laser therapy. They don't disturb the new vessels. Okay, this is the idea. What is the appearance is looking?
The retinitis pigmentosa.
It is clear to you because there is peripherally bone spicule appearance of the pigmentation. Retinitis pigmentosa. So is it involving only retina or choroid as well? What do you think? Is it the deeper layer of the retina or not? Sorry, is it deeper layer or superficial layer? It could be deeper layer. Otherwise, why this is black?
Yes, sir.
Deeper layer, the retina. Any other changes you observe in this picture? Please feel free, other candidates, please. Those who are with us, feel free to discuss. Any other observation? Anybody can say? What about the vessels? Is the vessels normal? I have shown you in the first slide that normal looking retina, we must know. Is the vessels good looking, normal looking? No, these are attenuated vessels, thin vessels, right? Thin vessels. But above the disc appearance, is it normal? No. No, this is also not normal. This is called waxy retina, waxy. So this is also optic atrophy. So what will be the term of the optic atrophy again? Primary, secondary, or consecutive?
Primary.
Farial again, please try to understand. Primary means optic disc is in problem. Other retina, part of the retina is normal. This is typically called primary optic atrophy. So
yes,
your retina is not normal. How can you say that this is primary? It could be secondary or consecutive. What could be secondary or consecutive?
Consecutive.
Yes, this is the consecutive retina. This is the consecutive the involvement of the retinal disease or the vascular disease. So this is the retinal disease, pigmentosa, retinitis pigmentosa. So it's the disease of the retina, and involve the optic disc head. This optic nerve head, the optic disc. Appearance is waxy. So basically, important three features try to remember: this spicule appearance, monospicule appearance, attenuated vessels, and the waxy disc. Right? This is retinitis pigmentosa. One technical question: what could be the visual field defect in this case? Visual field defect. Dr. Saida, you become silent. Can you think? It may be we can utilize our general.
It will be a tunnel vision.
Tunnel vision.
Tunnel vision.
Very
In
good.
retinitis pigmentosa, tunnel vision.
Tunnel vision, because the peripheral there is damages of the sensitive cells. Photosensitive cells are damaged, right? Only the central area is intact. So there will be tunnel vision, the constriction of the visual field. Very good. Yes, this is retinitis pigmentosa. Attenuated vessels, waxy disc. I already described before. So up to this, really, just to make the session interactive and having break to take deep breath, really. If you have any query in your mind, you can ask. Otherwise, you can switch to the next one. I believe that you will be with me so that we can finish today the other parts of the discussion. I hope that today's discussion will be enough for part 2 preparation, almost the basic understanding of fundoscopy. So we should not sit any further day. We can sit with other topic in another day. So thanking you to be with me until those who are here. So now some brief on diabetic retinopathy. I think you can be much attentive. It is very challenging. It is very challenging. So the first appearance, initial appearance, this is microaneurysm. This is microaneurysm, very, very small dots adjacent to the vessels. There are some small vessels. So if you cannot see very minutely, you may miss. This is called MA, that is microaneurysm, smallest red spots in the middle of the photo. Middle. Can you see? I hope you can see. This is small. It may be normal looking to you, right? This is microaneurysm. So if the aneurysmal vessels are ruptured, they produce dot and blood hemorrhage. Can you see any dot and blood hemorrhage? Can you see?
Yes, sir.
Yes. These are the dot and blood hemorrhage. These are the initial picture of diabetic retinopathy. What else here other than dot and blood hemorrhage?
Hard exudate.
Hard exudate.
Hard exudate. And what is the characteristic site of exudation? Perimacular. Perimacular. So this is very important area in the fundoscopy, in the central vision. Very, very important. Perimacular, because if macula is involved, there is a threat to the vision, immediate threat to the vision. So immediately we have to refer the case to the ophthalmologist. So maculopathy is not a progression of the disease, really. It is sudden deterioration of the retinal condition. In any stages, any time it may happen. So near the macula is very dangerous. So there are hard exudates. Hard exudates. Simply fatty appearance. These are exudation of the protein and lipid materials rather also in the retina. The next appearance is soft exudate. This is the cotton wool. Just we have seen before, right? Can you remember? Cotton wool. So cotton wool may be associated with the IRMA. IRMA may be intraretinal vascular abnormality within the retina. So what could be the IRMA? I will tell you a little detail that you are seeing there is some new vascularization appearance, right? The vessels are interwinged each other. It could be IRMA. It could be IRMA. But new vascularization also appearing. So there is a minute difference. I will tell you how to tell that this is new vascularization or IRMA. Be attentive, please. Just here. IRMA, actually, if we don't identify IRMA, we may mistake that there is neovascularization and it will be a matter of referral and it will be proliferative retinopathy. But IRMA is not a feature of proliferative retinopathy. It is just before the proliferative retinopathy. So you just have a look. IRMA in the center of the photograph, you see the spidery blood vessels, spidery appearance, very subtle, but the classic example of obvious and advanced IRMA in the center. Okay. Other features are the venous beading. These are the advanced retinal change, no doubt. You see the big vessels appearance having beading. Can you understand beading, Faria?
Yes, sir.
Yes, there is a beading. So again, VB, in short, VB. So there is IRMA as well as VB, yes. So this IRMA do not cross over major veins or arteries. This is the IRMA nature. IRMA nature do not cross over major veins or artery. But neovascularization will cross. Okay. And the IRMA typically represents either dilatation of the pre-existing capillaries or actual growth of new blood vessels. So this may be confusing within the retina, but this is within the retina, inside retina, whatever it is, but it may be also neovascularization. But just to differentiate in the retina, the new, though it could be neovascularization, it does not cross the big vessels, and they do not leak on fluorescent. Do not leak on fluorescent. You know the fluorescent angiography is done in the retina. It does not leak on fluorescent angiography. So this is characteristics of the IRMA. So their subsequent slides are coming just to differentiate IRMA and the new vessels. Can you look please carefully? This is new vessels elsewhere. This is new vessels in the disc. So they are crossing the big vessels. But here, these are the new vessels, venous beading, and there is IRMA. This is a small area. This is the IRMA. This is venous beading. This is new vessels elsewhere. So this is also new vascularization. This is also new vascularization. So
venous beading is just this point, arrowing that point, venous beading.
Interrupted continuity of the vessel wall. This is not smooth continuous. This is interrupted. This dilatation, whether to say abnormal dilatation is there, like bronchiectasis in the lungs.
Oh,
like bronchiectasis.
This is very smooth dilatation.
Yes, dilatation, narrowing and the dilatation. So this is showing that advanced diabetic retinopathy. Advanced diabetic retinopathy. This changes. Anyway, I think I tried my best to show you the difference between IRMA and neovascularization. So this is very advanced diabetic retinopathy. You see there are some new vessels, but there are some white area, fibrous tissue is proliferated here, and vessels are becoming less. This is the fibroproliferative retina. Extensive fibroproliferative retina. It is called FPDR. FPDR. Fibroproliferative retina. These are actually common in low-set countries like ourselves. In neglected patients, very long time diabetic, they may have this type of fibroproliferative retina. So it is a point of no return really, right? And wherever the fibroproliferation, there is a chance of bleeding. So it can cause retinal bleeding, pre-retinal bleeding or the retinal bleeding. It can detach any time. So this is the bleeding, and is it retinal hemorrhage? We have seen dot hemorrhage, blot hemorrhage. What else? That one, flame hemorrhage. So is it what type of hemorrhage? First question, is it inside the retina or in front of retina? This is in front of retina. This is in front of retina. This is pre-retinal hemorrhage. Pre-retinal hemorrhage. As the blood obscures major vessels, retinal vessels behind is not visible. So this is very simple clue that this is pre-retinal hemorrhage. And the pre-retinal means it could be vitreal hemorrhage. It could be hemorrhage due to many other issues, some medical diseases also. There may be coagulopathy, or maybe the local retinal diseases, rupture of the retina, it causes the bleeding. So again, in a summary, you see that different changes of the retina. There is a hard exudate, right? There is a bleeding, including coronal spots. This is neovascularization, and this is the laser coagulative retina. And the last one I added actually with the book, fibroproliferative retinopathy. I think this picture may be helpful for you for preservation in future. It will be helpful for you if you can make a snapshot of this. So now coming to summary of the diabetic retinopathy, non-proliferative, pre-proliferative, proliferative. And the last one in the part of the proliferative, the later one, the fibroproliferative. Fibrovascular proliferation is there. Sometimes it is told that FPDR, fibroproliferative diabetic retinopathy, fibroproliferative. So these are the characteristic features. And the maculopathy can happen anytime in the diabetes. So now how to differentiate? This is a challenge, especially in the patients also. So this is the hypertensive retina, red spots are there. There are also coronal spot, more common in the hypertensive. There could be hard exudate. Hemorrhages are actually flame shaped, but these are the very important changes. Silver wearing, copper wearing, and there may be what I say, blood optic disc. Blood optic disc. It can happen in the diabetes as well, no doubt, because diabetes also can cause vasculopathy. So sometimes a significant number of patients having diabetes and hypertension both together. So picture may be mixed. Picture may be mixed. It is also true. I think up to this, do you have any query? No. So this is a summary, just preponderance feature in the hypertensive retina and the diabetic retina. All are almost more or less in the both retina, but there are some fascination, inclination of the features in the diabetes and in the hypertensive. But truly speaking, picture may be mixed. Okay. Again, taking a deep breath, 1 minute. Many of you know about the diabetes, hypertension many days before. But if you want to discuss anything up to these, it is a break time for you. So I think I spend more than 1 hour now. Even then, I'm really excited to discuss this thing. I'm not sure, are you becoming tired or not? If you find this is hopeful, I can continue a little more. What do you think?
Yes, sir.
Can we continue?
Yes, sir.
Okay, good. Very good. Just try to be with me. I hope that definitely, I believe this class will be very helpful. So now look at the picture, what you are looking. If anybody willingly can say.
Angial streak.
You are thinking that there are angioid, but not angio. These are not vessels, but like vessels is strict.
Yeah.
Is strict, angioid. Okay. Any other observation? Is the optic disc okay? First look at, yes, optic disc is okay. Vessels are coming from the center. There is normal optic cup and the yellowish color of the optic disc. So we cannot comment that this is white optic disc or reddish optic disc. Vessels number are normal. The macula is there in the center, but there are some what I say scattered white areas as well as pigmentation. White areas and pigmentation. So Dr. Farial, which picture you are telling that this is angioid streak?
So this the under underlining the vessel, the white thing
No, no, no.
around the
I know why the our doctor.
underlying the
No, this white area you mean? The white area the streaking?
no, that's not only the, not the white only, but the like some kind of vessel is going
Oh,
whitey.
yes, seems to be. But if you hardly look at the vessels always coming from this center, from the optic this center. All the vessels, all are the branches. If the branching light not coming from the vessel, it could be NGR district. It could be NGR district. But unfortunately, I cannot agree with your observation. There is no NGR district. So this is damaged retina. Now the question is the retina damaged or as well as choroid also damaged? What is your opinion? I told a little before. Is that simply retinal damage or choroid also in damage? Mahabu? Choroid also damaged because there are pigmentation, scattered pigmentation. So this is what gray-white patches. Gray-white patches means you can say that this is retinal damage, but as well as the pigmentations are there. So this is choroidal damage. So this is old choroiditis. Old choroiditis. That means the patient having disease in the choroid before. So retinochoroiditis could be there. We can utter the word retinochoroiditis or chorioretinitis. Both are same. Both are same. So as we told, this is old choroiditis. It is a very common picture. It may be common in PACES exam because old case. But as a part 2 examination, you may face the acute choroiditis. But acute choroiditis in practical situation, you know that may not appear in the exam. So this is acute choroiditis again. Look at the choroid. There is a white spot. Okay. Beside the macula, there is a spot. Can you see, Mahbub? Another colleague, please.
Yes, sir.
Rafid, Dr. Beg, and the side also. Here. In the center, beside, there
Yes, I can see.
This area is not much clear cut. Okay. There is some pigmentary area. There may be again the pale area. There is a pale area. Subsequently, change happened and the disease is progressed. You see, this spot is becoming clear more and this spot also almost clear. Can you compare this? Same,
Yes, sir.
Same area. So this is advanced stage. When you find this clean cut white, it could be old choroiditis. Old choroiditis. So choroiditis may be in the macular area, peridisc area, other area, maybe focal, multifocal, diffuse, central, juxtapapillary. Papilla means optic disc. Many where there may be choroiditis or chorioretinitis. And this appearance, like these are almost white, not very diffuse. Okay, so why there is diffuse appearance initially? Because there is inflammation, there is fluid, there is exudation. So this appearance is edematous appearance. So this is acute. And as there is dry almost, less edema, there is a scars. So this is old choroiditis. And very important differential diagnosis is here. Most commonly tuberculosis, syphilis, right? Sarcoidosis and infiltrating disease also can cause this type of appearance. So look at these first, then diagnose underlying disease. This is the challenge. So this is the choroiditis. Again, I think in this chapter, I believe that our candidates and regarding myself also, in my initial stages, we actually know very less about these appearance, this area, the choroiditis and others. So look at the picture again. There are multiple yellowish area, right? Okay, Farial, can you see multiple areas in the retina?
Yes, sir.
Here also multiple areas, but in the central area, the white becoming thicker and persistent looking, and there is pigmentation. Can you see? There are pigmentation. So again, this is initial stage of the choroid or chorioretinitis. This is the later stage of chorioretinitis. There are many differential patterns in ophthalmology. It is beyond my capacity really. So as a clinician, we should not know detail everything. They're telling it is subretinal fibrosis and the uveitis syndrome. Usually the people were not going to this chapter in that manner. Our idea, my idea actually just to differentiate in the lower two boxes, the basic differences are given. I think again requesting you, if you make a snapshot, it will be helpful for you. It is my collection really, not as it is in the book or anywhere. So please get it with you. Okay, this is choroiditis. So subsequently there will be optic disc change also, right? If any disease involve the disc, involve the retina, like sarcoidosis, tuberculosis, you know, the granulomatous disease, they can involve the disc. Again, there will be optic atrophy. Again, asking you, what will be the diagnosis of that optic atrophy? If retinal disease includes optic atrophy, primary, secondary, or consecutive? It will be consecutive. Consecutive optic atrophy. If the disease process involve the retina, usually involve the retina because retina and the choroid are close together. So this will be consecutive optic atrophy. Okay. What could be the diagnosis? I think it is easier now.
Toxoplasma.
I am not asking the etiology. Tell the appearance. Well-known picture for the part 2 examining, right? In the learning bundles. Should we say this is retinitis or choroiditis or chorioretinitis or optic atrophy? What else?
It is chorioretinitis with optic atrophy.
Very difficult to say, doctor. These actually it is not quite and the margin is visible. Not, if you want to say that this is distinct margin at the time, but the optic disc not completely white. It may be optic cupping. Dr. Mahbub, it could be optic cupping.
Yes, sir.
Optic cupping. So we cannot be tell it is very confidently optic atrophy, but it may happen. If any choroid retinitis is there or retinochoroiditis is there, there might be. But this very appearance, pigmented, there is a white patch. And can you imagine that this white patch could be a sclera? Can you imagine? Is not possible. This very, very bright white area, the whole choroid is damaged and the sclera is visible. It can be possible. The bright red area. So it is, this is not confined only in the retina. You see the whole retina is damaged. There is no vessels also visible. The remaining retina is intact. There is also pigmentary area. So this is choroidoretinitis. And Dr. Pariali said in etiology, it could be toxoplasmosis. But can you say what the very characteristic feature to tell it toxoplasmosis, Dr. Pariali?
One is so chorioretinitis will be the feature.
Yes.
Yeah.
Maybe extensive damage happened by the toxoplasmosis in the in the eye wall, rather wall of the eye, right? If you tell retinitis, only retinitis. If you tell choroiditis with retinitis, choroidoretinitis, you find that the sclera also visible. It may be the features of toxoplasmosis, but we should not be confident. We can diagnose the toxoplasmosis with other features. And what will be the age and gender of the patient? Possibility here in general. Is a quiz.
Young patient.
Young patient in reproductive age. Now you understand? Young patient in reproductive age. Because toxoplasmosis is a disease of immunocompromised state, more likely HIV. So HIV can produce such choroidoretinitis itself, and the opportunistic infection can cause the same. So this is more likely toxoplasmosis. Retinal pigmentation is there, gray-white patches which are scattered. Yes, but very grossly visible. Very grossly visible. Now, is there any white patches? Is there any pigmentary change in the retina? Yes. What other features also? Is the pigmentary change are more visible in the first picture, or white changes are more visible?
White patches are
more visible, but they are also, sorry, I have to prepare myself. The second picture, there are some pigmentary changes. So could it be choroidoretinitis? Could it be?
Sir,
Yes. Yes.
Yes, choroidal retinitis.
Yes, it would be correlated, especially the second one, as there are pigmentary changes also. But here, pigmentary changes are not grossly visible. Okay.
correct.
Yes. So what will be, which one will be initial stage? What will be the later stage? First picture or second picture?
First one, initial.
Maybe first one initial. It may be second. Whatever the etiology, maybe toxoplasma, maybe cytomegalovirus, maybe candida and other. But it is told in the textbook, you know, the appearance of viral retinitis, there is called pizza pie appearance, cottage cheese appearance. Many terminologies are there. So if it is mozzarella pizza or pizza pie appearance, what could be the diagnosis etiologically? Can anybody say?
Cytomegalovirus.
Cytomegalovirus. And you can find that in the book. It is told as CMV retinitis. Most commonly, the word used as CMV retinitis, not choroiditis. Can you remember?
Yes.
CMV retinitis. That means the virus have more affection to the retina only and less affection to the choroid. But it can happen, no doubt. So both pictures showing this is CMV retinitis. So this is retinitis and there is a bleeding also. And this is also pigmentary change. Both may happen, but primary features is the granular zone of retinal necrosis. The white area is the retinal necrosis, variable degrees of hemorrhages, and the low-grade iritis and vitreitis. So iritis also there, iris and the choroid in the same layer, is not it? Middle layer of the eyeball, iritis may be there, but choroiditis is less. Can it be confused with the hypertensive retina? This picture, just think of the first picture. Can it be confused with the hypertensive retina?
No, sir.
Not
Why?
actually.
Maybe there is a bleeding. There is an suppose the damaged retina, white, ischemic retina. But where is the silver wearing? Where is the copper wearing? Where is the arteriovenous nipping? Minimum 1 or 2 features should be there, right? You see the optic disc is blurred, so it may be papilledema also. But there should be other grade feature also, grade 1, 2, 3. There is nothing. And there are no hard exudate visible, but there is only damaged retina visible by the white patches. So it may be confusing also. It may be confusing with the hypertensive retina. For that, I have shown you many big list also, big list of diabetic, hypertensive retinopathy before, as there is hemorrhage. Anyway, what is this? There are it is very easy now to identify. Can you say, other than Dr. Farial, can you identify what is wrong here? Anyone, please? Can you identify?
Choroidal vessel.
No, these are not vessels. Vessels should come out from the heart and its branches. So these are the vessels, the red areas. But in the black lines, curved lines, right? Spiral lines, these are not coming from the central area, not part of the vessels. These are damaged brush membrane of the retina.
The angioid streaks?
These are the typical angioid streaks. This is my collection from the net. I am astonished really. Like Farial and other colleagues also, when I was preparing, I have seen this angioid streak in the question bundle. You can remember in the on exam, there is a picture. It was actually confusing me before because there were some white areas are there, very faintly visible these marks. So I was confused. Which one is the angioid streak? Is it the white area or that area? But after discovering this one, it was very clear to me. This is angioid streak. Again, there may be some degenerative disease in the retina, right? Maybe consequence of chronic inflammation is there. So there are causes of angioidystic. You can remember the mnemonic was there. Can you remember the mnemonic, Dr. Farial? Causes of angioidystic. One is the Paget's disease.
Yes, sir.
Paget's disease. There are some other
Xanthoma elasticum.
Xanthoma elasticum and other, even other common diseases also. These slappers maybe.
Flappers.
Slappers. Mnemonic is slappers. Try to remember it. Try to
Yes.
remember it.
Acromegaly.
Yes. What is the appearance looking?
Cytomegalovirus. Pizza retina.
Is it pizza?
Pizza retina.
Pizza will be this black. How it could be to be eaten, this black pizza, like that?
So this red.
There are some reds,
Red, yeah.
maybe sauce,
Sausage.
tomato ketchup maybe, but what about the black things? Dirty. The vessels are attenuated also. Vessels are not that much in the normal retina. And optic disc seems to be normal. There may be optic cupping. What do you think, Dr. Mahbub? Maybe optic cupping is there. Normally,
Yes, sir.
cupping is there, but other retina is normal. So
Increased cup disc ratio. Yeah.
maybe ratio near 50%, not that much. But there is a damaged retina. It seems to be that it will consecutively involve the retina optic disc later. Then we will tell it consecutive optic atrophy. But here the appearance is called this type of blackening, sunburst retina, sunburst. So these are sunburst retina, and there are some other. It may be the acute stage of the retina. It is called salmon spot. So what could be the diagnosis? Can you say, anyone? This is sickle cell disease, and it is told that it is very pathognomonic of sickle cell disease in the retina, though it is not much common finding. If you find this sunburst retina, it could be sickle cell disease. So it is found in the sickle cell prevalent country in the world. So if anybody can have seen, you can share with us. These are the salmon spots. This is the sunburst retina. And this retina, what is telling? This is a reddish spot, but containing a big whiteness. Focal area. Other part almost normal. What could it be? Don't worry, we are actually at the end of the discussion. 2 minutes remaining. This is one example of choroid tubercle. Choroid tubercle. So name is telling that the tubercle is in the retina or the choroid. Sclera choroid. So this is the choroid. So
Tuberculosis.
Yes. No, I'm telling the choroid tubercle is a tuberculosis, suggestive of tuberculosis. So this is a focal granulomatous lesion in the retina, more likely in the choroid. For that name is choroidal tubercle. Choroidal tubercle characteristics as such shown here. Just make a snapshot so that I should not tell. This is one presentation of this focal feature. Another, this is the other characteristics of the tuberculosis in the chest, in the CT scan, miliary shadows, in the brain tuberculoma. Again, in another picture, multiple choroid tubercles in the retina. So we could be confused. Could it be choroiditis, right? Could it be white cotton wool spot or many things? So we are dealing not only retina, we are dealing a patient history, other examination, other investigations. So it will be very easier to diagnose. This is the choroid tubercle. I think few minutes only remaining for you. I hope that I can finish. This is another spot. What is the difference of this spot with the previous one, Dr. Mahbub? In the previous one, there is almost white, right? But here,
Yes,
it's almost red. Almost red. Only central area is the white. Central area is the whiting. So there is a gross difference between these two pictures. So what could be the diagnosis here? Just I'm sharing another picture also.
Rock
This,
spot.
this is the red area. This is actually hemorrhage and the central area. So this is very classic example of Roth spot. Very, very characteristic of what?
Infective endocarditis.
Infective endocarditis. They are also focal retinal damages. There is a bleeding, and inside in the center, what is the paleness? Is a pale white center. This is very characteristics of red, sorry, the Roth spot. Just try to remember, can be helpful for you. Red containing white. Red containing white.
White.
R for R. So red surrounding. It is Roth spot. It may be positive in any other inflammatory disease also, in the tuberculosis, sarcoidosis, many. But very commonly, this is very diagnostic of Roth spot, diagnostic of infective endocarditis. Now these are your challenge. Given in the first slide, what will be the diagnosis now? Please.
This is infective endocarditis.
Very easy now becoming. Anybody else of difference of opinion?
Yeah. Rock spot.
There are retina almost normal, disc almost normal, but in the near the disc there are some bleeding area containing white. For that, Dr. Mahbub, you are telling?
Rock spot.
So I told you that Roth spot, it may be Roth spot, but there may be some other differential diagnosis also. Could it be tuberculosis?
Yes.
Could it be tuberculosis? Less likely. The tubercle appearance is little different, not like this hemorrhage. Not like this hemorrhage. Less likely could be tuberculosis. But if we want to actually confirm the diagnosis for very critical situation, we need to take some biopsy also from there. It is not usually done. But the very presentation of the female patient with the fever, chills, that means acute febrile condition with confusion, fundoscopic appearance is very, very suggestive of infective endocarditis. So thank you very much. I think
Thank you, sir.
finished with the appropriate time, and we assume that we could finish within 90 minutes time. I think we have done it. So my heartful thanks to all of you who were with me until now to complete the session of fundoscopy. I hope that it will be very helpful for you, in my sense, really, as I was in your situation, and that much thing actually was not clear to me. I know it. So as we are here, I believe, and my request will be to you that you just disseminate the information to others so that we can make many more successive sessions for the part 2 especially, and within few days we will like to inform you. And many of you newly passed part 1, we are planning to make make an organized study group really for that in future. We will let you know in time. So I like to thank you again. If you have in your mind to tell me something for suggestion of any comment also of this arrangement, you can share, especially those who couldn't tell. I find Dr. Rafid is here, Dr. Sahir.
Hi.
Any comments?
Hi.
Please, welcome.
Yeah, this is Dr. Saida speaking.
Oh, yeah.
Actually, I missed a lot of the session, which is very interesting, very well organized. I'm really thankful to you.
Wow.
It is an eye-opener for me, really. This fundoscopy is, I almost know, no, I don't want to say know nothing, but know very little.
Yes,
Thank you for this very helping session. And I will ask anyone who recorded this, please, if we can share it so I can attend it again.
Oh,
many times, because I'm on duty and just like maybe 10% of it I attended.
Oh, sorry, really.
Thank you very much.
Thankful that you in your duty time also you tried to attend our session. And you are from? May I know?
I'm from Abu Dhabi, UAE.
Oh, fantastic. Known to us also like Abu Dhabi. Fantastic. So we hope that we can get you. When did you pass your part 1? Part 1 exam? Hello.
When do I pass?
Yeah. part 1 MRCP? Hello.
Yeah, 1.5 years ago.
Okay, okay. So this is your good time to appear in the part 2 exam now. If you take more time, may be difficult for you. The memory will be hazy. So try your best to appear. Good. I think Dr. Sahir Atharbek like to tell something. Please.
Sir, I just want to ask, initially in the session you asked about the fundoscopy, how we are going to tell which is the right side and which is the left side. I'm still confused in it.
Confusing. So can I go a little back? If you give me
Yes,
time.
sir.
If you give me, suppose this
Yes.
picture. Suppose this picture. So as we focus the light towards the eye, possibly you have seen it. The doctors are doing the fundoscopy. You have done also obliquely from the lateral side. So you are focusing the optic disc medially of the eye.
Medially, okay.
So,
Right, sir.
so this is the macula. So usually macula remain in the lateral side of optic disc. So what will be the eye, right or left?
So this should be the right eye.
Definitely. Thank you very much. This should be
Okay.
the
Thank you,
right.
sir. Thank you, sir.
Thank you. Thank you very much. Dr. Dr. Beg, you are from?
Sir, I'm from Pakistan, but I'm residing in Riyadh.
Oh, Riyadh. Oh, fine, fine. Well known
Yes,
to
sir.
me, really. I was there many years. Thank you very much.
Okay, mashallah. Thank
Okay,
you, sir.
see
Thank you,
you
sir.
again in the coming classes. We hope that we can arrange another class. I was thinking to make a session of MRI and the CT scan. Some basics, definitely. CT scan and the MRI. Not a detail in clinician's view. I hope within week we can arrange one such program. My request again to disseminate to your friends and others. Thank you very much. See you. Bye-bye.
Thank you, sir. Assalamu alaikum.
Mm.